I'm Rochelle Wynne. I'm a member of the Connect Group based in Melbourne, Australia. I work as a clinical nurse consultant in the Department of Cardiothoracic Surgery at the Royal Melbourne Hospital, and I'm an honorary professor at the University of Wollongong and editor-in-chief of Contemporary Nurse Journal. This presentation is focused on outcomes reporting, more specifically on what, when and why patients' perspectives matter. Patient-reported outcomes are reported by the patient without interpretation of the patient's response by a clinician or anyone else. PROMs, as they are commonly referred to, are the tools or instruments used to measure patient-reported outcomes. Before we consider patient-reported outcomes in the context of cardiac surgery, it's important to acknowledge the steady maturation of patient and public involvement and co-design in health services. Patient and public involvement places the patient at the centre of what we do. It promotes a culture of meaningful engagement, and it involves participation from individuals and from the communities we serve. Patient and public involvement is informed by insight and experiences, and there is a logical progression of steps to consider within the mechanism of patient and public involvement. We need to devolve our services to inform community and individual decision making. We need to collaborate so that our decision making considers alternatives and preferred solutions in partnership. We need to involve patients and the public by working directly with communities and patients to ensure their concerns and their aspirations are heard and considered. The process requires ongoing consultation, and we need to obtain feedback on analysis, alternatives, and decisions. And lastly, we need to inform patients and the public by providing objective information to assist in understanding the problems, alternatives, opportunities, and solutions that can be developed. Co-design brings stakeholders together to address problems and progress solutions collaboratively. It builds confidence, consensus, ownership, and accountability, and it produces community-led products, services, and policies. There are drawbacks with co-design, particularly in health services settings, that relate to poor inclusion strategies, domination by clinical experts, and narrow mindsets that do not necessarily accommodate individual or community views. Patient and public involvement and co-design are fundamental for knowledge translation and the uptake of acceptable and feasible evidence into practice. Patient-reported outcomes provide an opportunity to test the feasibility and acceptability of interventions. Despite the growth and acceptance of patient and public involvement and co-design, the implementation of evaluation using patient-reported outcome measures is highly variable, particularly in the context of cardiac surgery. PROMs focus on patients' perspectives rather than traditional measures such as physiological outcomes, survival, morbidity, or mortality. We need the patient's perspective because therapeutic interventions are multidimensional. For instance, a new drug may demonstrate good clinical outcomes for a particular patient group, but patients are non-compliant because of side effects or poor quality of life, and that renders the drug ineffective at scale. Patient-reported outcome measures can be broad or disease-specific, and they traditionally include health-related quality of life, functional status, symptoms and symptom burden, health behaviours, and the patient experience. A systematic review published in January 2023 unpacks the complexity involved in the routine collection of PROMs. The authors of this review found disease-specific patient-reported outcome measures were most commonly collected, and when collected, they were focused on body impairments and participation in activities of daily living. The most common generic PROM was the health-related quality of life measure, the EQ5D, and collection in clinical care was usually paper-based. Although traditional measures are well established and widely accepted, they do have drawbacks. They can lack specificity in terms of what patients consider important. They reflect self-reported capability rather than actual performance, and reporting can be uncomfortable for patients, particularly if they feel vulnerable in the healthcare context. And of particular importance, there is actually insufficient evidence to indicate that enhanced healthcare decision-making occurs as a result of patient activation. Models of care based on patient experience imply that the patient is central and their care is individualised and customised for the patient rather than the clinician. But the transformation of healthcare systems from clinician to patient-centred is far from complete. Patient control over healthcare decisions is only useful if there is complete transparency in evidence, cost, process, outcomes, and errors. Claims for patient control have, however, been largely ignored. Institutional inertia, a lack of financial incentives, and the primacy of healthcare professionals means that clinicians too often perceive confrontation and frustration rather than partnership with patients, and there are few incentives to change this orientation. It's postulated that the primacy of physician professionalism stems from professional control over scientific knowledge, and the nurse professionalism from control over the practice environment. The professional model rings true in the context of acute illness where treatment was, in the past, focused on cure. But in this century, healthcare is focused on managing chronic illness in the context of an expanding, ageing population. Healthcare outcomes are much less obvious as they extend beyond curing disease, and multimorbidity necessitates trade-offs amongst treatments, conditions, and possible outcomes. Patient priorities are the medium necessary for productive, collaborative partnerships underpinned by co-design and patient and public involvement. Defined as a combination of specific and realistic outcomes that individuals want based on what matters to them, and the activities, including taking medications, self-care, tests, and visits, that they are willing and able to perform to achieve these goals. Evidence and professional judgment guides relevant treatment. Clinicians partner with patients to select and adjust care. Care is based on patient goals rather than individual disease states. Pragmatic studies demonstrate that this patient priorities approach to care reduces polypharmacy and patient-reported treatment burden, while increasing care that aligns with patient goals. Patients and clinicians describe the process as practical and beneficial. Novel quality measures are necessary. Studies exploring quality measures of goals-based care have compared goal attainment scaling with PROMs. Collaborative goal setting and care preference was assessed using a 5-point scale. Clinicians and patients discussed, then individually related degree of goal attainment. This approach was contrasted with that of an agreed PROM to assess change over time. Findings indicate that clinicians and patients were more likely to implement goal attainment scaling. Clinicians found this approach more useful for determining which services and supports to recommend to help patients achieve their goals. And contrary to common assumptions, clinicians and patients set goals collaboratively and focused on patient-centred outcomes rather than disease processes or biomarkers. These findings suggest that implementation of a goals-based approach in routine care is feasible and demonstrates promise for fostering the shift from disease to patient-centred care. Furthermore, we must ensure that the measurement of patient-reported outcomes is inclusive and equitable to address the diverse needs of all patients with a condition of interest. Patient-reported outcome ethical guidelines have identified a number of aspects of outcome measurement that require further investigation. There's a lack of representation that leads to population bias and findings that are specific only to certain groups. There are many barriers to reporting completion. Many patient-reported outcomes are developed without sufficient patient input. They don't address patients' concerns, so they don't get completed. And digital exclusion affects approximately 37% of the global population, particularly marginalised groups. There are racial and ethnic disparities. Translated, culturally appropriate patient-reported outcome measures are unusual. There is a negative linear correlation between economic income and participation in research, with lower middle income countries underrepresented. Access to technology, disability, health literacy, language and cultural requirements must be addressed in the interests of fairness and to ensure results are as accurate and generalisable as possible. Participation needs to be widespread. Patient and public involvement is central to promoting inclusion and accessibility for patient-reported outcome assessment. Involvement promotes recruitment. Empowering patients from underserved groups to inform the design and delivery of outcome measures allows for the identification and mitigation of barriers to successful patient-reported outcome implementation. User-centred design can create functional tools for patients and providers. User-centred design principles can accommodate for people with visual impairment, limited mobility, learning disabilities and low health literacy. To improve care for all, patient-reported outcome measures must reflect diverse, multicultural societies. New medicines and technologies must be applicable to the subgroups that they are intended to serve. Including underserved populations in patient-reported outcome assessment will promote equitable healthcare. Codesign is central to successful realisation of this equity. In summary, patient-reported outcomes require patient and public involvement and co-design to be relevant. There are highly variable rates of collection of traditional PROMs, and the populations from which they are collected mean the reality of the information they reveal is very limited. In contemporary cardiac surgical care, we need to move beyond tradition to innovation that's focused on patient-centred care that considers patient priorities. When patient-driven goals are the priority, clinicians and patients are more likely to implement strategies for goal attainment. Patient-reported outcomes and outcome measures must be inclusive and equitable, designed by users. This approach will ultimately improve care for all patients. Thank you for your time today. Do consider joining Connect and being a part of future possibilities.